Welcome to our webinar on residential aged care facilities, COVID-19, temporary MBS item numbers and Medicare update. Our learning objectives are to identify the residential aged care facility temporary MBS changes for GPs, allied health services and psychological service providers, and to apply that learning to coordinate and deliver care for aged care residents. What we're going to cover in today's session is an overview about how these additional services have come to be in place. What did those current pathways look like for residents in terms of access? An overview of the temporary MBS item numbers. And we're also going to have a look at the case conferences and some other new item numbers that are now available. So we'll start with COVID-19 and I guess the impact that it's actually had on aged care and how these recommendations and services came to be in place as they are at the moment. So a number of reports and recommendations kind of led to that. And there's three main reports that we're going to have a look at. So the first one is the aged care and COVID-19. This was a special report that outlined 6 recommendations. Recommendation 3 was that they should actually create the MBS items to increase the provision of allied health services, including mental health services for people in aged care during the pandemic. The next report was the National COVID-19 Aged Care Plan, and this outlined 3 main factors that contributed to the deconditioning of residents. This included psychological, nutritional and physical, and just recognise that allied health actually play a really major role in the prevention of the residents' decline as much as they do in the rehabilitation. And then the final report that we have is the Royal Commission reports. Now there's 5 volumes in total for those that haven't had a chance to have a look at these. If you just wanted an overview, I would just go straight for volume 1. This provides a background to the Royal Commission's inquiry, explains everything from how it was conducted, presents a summary of the final report and lists all recommendations. So that will give you a nice overview of the full inquiry. So that's how we came to get some of these new MBS items that are now in place. So let's have a look at what the allied health pathway actually looks like for residents. Residents can receive allied health services under the Aged Care Act. Now, under this legislation, approved providers of residential aged care services are actually required to provide therapy services, and this includes things like recreational, speech therapy, podiatry, occupational therapy, and physiotherapy services to certain residents at no additional cost, and this will be defined by the residents' funding classification. For residents that have complex care needs, they can also receive allied health under their Medicare chronic disease management items. So that would entitle them to the 5 individual allied health services each calendar year once the GP has contributed to the care plan prepared by the facility. So that would be under item 731. So let's have a look at some of these pathways. So up until the 30th of June 2022, the temporary MBS item numbers that are available to support residents will be under these 3 main pathways. So these are the existing pathways under the multidisciplinary care plans, type 2 diabetes and Aboriginal and Torres Strait Islander health assessments. So under those new items, it means that the allied health providers can claim a call out or flagfall fee to cover the cost of the travel to the residential aged care facility to provide those face-to-face services. Let's have a look at the existing allied health pathways. So after the 30th of June, these existing pathways will be back in place. So there's 3 main pathways that are available. So the first on the left-hand side, we've got the resident has a residential aged care facility care plan, plus the GP has claimed the MBS item 731. So as we said, that was for the residents that have that complex care to receive additional 5 individual allied health services. So for those GPs that are unsure of the paperwork, we'll have a look in a moment and show you those referral pathway forms that you'll need. The next option is if the residents completed Aboriginal and Torres Strait Islander health assessment. So that's an additional 5 individual allied health services for those residents. And if the resident has type 2 diabetes and the residential aged care facility has a plan in place and the GP has contributed, then this would make the group allied health services available. So the temporary pathways is what is available until the 30th of June. So on top of those existing numbers, it would be 5 additional individual physical therapy services. So that includes physio, exercise physiologists, and occupational therapists. And if the resident has type 2 diabetes, on top of those 8 services, there would be another 2 additional allied health services. So the group sessions are a little bit different. It's not all providers, it's specifically diabetes educator, dietitian, and exercise physiologist. So this one's just addressing the EP, those additional numbers. So for the GP to be able to contribute to the resident's care plan and claim that Medicare rebate, the plan needs to be multidisciplinary. So this means that the resident must have a chronic medical condition and complex care needs that requires ongoing care from that team. So we need at least the GP and 2 other health or care providers. Okay, and that will depend on the needs of the resident. So the referral form that we would use once you have the multidisciplinary care plan in place is the same form that we would use in general practice. So it's the exact same enhanced primary care form, so the EPC form that we would use for patients that had a GP management plan and team care arrangements. The only difference is instead of ticking that first box saying that they've got the 721 and 723, it would be that they have the 731, so that contribution to the multidisciplinary plan. So with the referral, they kind of recommend that the GP and the residential aged care facility should work together to assess and plan the care for the service needs of that resident. The GP is responsible for identifying the need for the allied health services and for making those referrals. Once the 731 has been billed, the other referral pathway is for those residents that have type 2 diabetes. So this is to actually access the group services. So it's the same referral form that we would use in general practice for the patients that have a 721. So it's the same form, except instead of selecting that the patient has a 721 in place, it would be that they have the 731 completed. Okay, and under this pathway, once those 8 services have been used, then they actually get the 2 additional services under those temporary MBS items. And the last referral pathway, just with the referral forms, is once the resident has had that Aboriginal and Torres Strait Islander health assessment, then they're also eligible for the other allied health visits under that other pathway. So it's an additional 5. This allied health referral form is the same one that we would use in primary care. So instead of ticking the 715 as we would in general practice, we would actually tick one of the time-based item numbers for this health assessment. We're going to have a look at the mental health and that referral pathway as well. So how residents can actually access the psychological services. The current care pathways for residents is often really complex and delivered by multiple providers. So usually got the GPs or other medical practitioners. For those accessing mental health, maybe registered psychologists, social workers and occupational therapists as part of that care team. So the Better Access initiative was introduced in November 2006. There has been some changes with COVID to assist with some of those additional items. So the whole idea was to improve the treatment and management of mental illness within the community. Eligible patients could actually receive up to 10 individual allied mental health services and up to 10 group allied health mental services. So this has been extended during. So the extending of that mental health support for aged care residents during COVID-19. And there's a number of fact sheets as well. So all of those are in the links at the end of the presentation. So eligible aged care residents can actually access up to 20 individual allied health services each calendar year. So that has actually been extended up until December 2022 this year. These services don't have to be delivered just face-to-face. So it can be face-to-face in aged care facilities, telehealth, or in the practitioners' rooms. So the eligible residents for this pathway, they need a diagnosed mental disorder, and it's for those residents that would actually benefit from structured multidisciplinary approach to actually manage and provide treatment. The mental health services that can be provided. So we've got psychological therapy services. So that's for eligible clinical psychologists, and then the focused psychological strategies. So that's for eligible GPs, other medical practitioners, registered psychologists, social workers, and occupational therapists. Now I've got the links to the mental disorders in primary care that just breaks down the categories of the mental and behavioural disorders. And for residents to be eligible, it needs to be in line with the broader Better Access Initiative support. So those with a diagnosed mental disorder that would actually benefit from that structured approach. And I've got the link to that included. And dementia, the ones that are highlighted there. So we've got dementia, delirium, tobacco use disorder, and mental retardation are not regarded as mental disorders for the purpose of this particular initiative, but obviously may coexist with other mental disorders. So there's two ways to access mental health support for residents. So for those GPs that are unsure, we've just broken it down into a little bit of a step-by-step just to help with that referral pathway. So there's two ways to access the mental health support under Better Access. The first one is through the mental health treatment plan by a GP or other medical practitioner. And the second option is for the psychiatrist assessment and management plan. So to access that support under Better Access, aged care residents require an approved mental health treatment plan that's developed by their GP. Once that plan has been completed, they can provide the resident with the referral for the mental health services under the Better Access. So there are some sample templates. If you think you want to have a look at your current template that you're using, there's some sample templates available on the Better Access page, and the links there as well. The Better Access initiative resources, they've also got a lot of things there that may be useful. So they've got fact sheets for residents and professionals. They've got the mental health treatment plan templates. And then they've also got things like frequently asked questions and guidelines that you can look at as well. So step 2 is to actually generate the referral. Now they've got a list of requirements of what should be on that referral. So we've got the basic demographics, so name, date of birth, address, the diagnosis, any medications, and then the number of sessions that they're being referred for, so the course of treatment. So once we have the plan, we've got the referral with the number of sessions. Okay, and we can do a maximum of up to 6 on that initial referral. And they call that initial referral the number of sessions that delegated the initial course of treatment. There's usually frequently asked questions around, can that referral for Better Access services be used across multiple calendar years? It's saying yes, it can, as long as there's no more than those 20 services in any calendar year. So the initial course of treatment can be completed by the GP, other medical practitioner, psychologists, social workers, or occupational therapists. Okay, that's that initial course of treatment. Some of the frequently asked questions around that are things like, are those practitioners required to bulk bill aged care residents? The answer to that one in the MBS fact sheet was that there's no requirement for practitioners to bulk bill aged care residents, and that it's at the practitioner's discretion to determine the appropriate billing arrangement for the aged care residents. Noting that, of course, the aged care residents will only receive the rebate amount attached to that relevant MBS item number. Now, step 4, we have to actually review the mental health treatment plan. So the review for this, following the completion of that initial course of treatment, the GP must review. So they must undertake the review. If they consider that the resident would actually benefit from additional sessions, they can provide a referral for up to 4 more under their Better Access sessions. Okay, and then they've got, do you actually need to claim that review item when referring a patient for the additional session? So they're saying if the resident has already received a review of their plan in the last 3 months, then you can't actually claim another review. That's just down to the claiming restrictions. Where a practitioner is referring the resident for further course of treatment within that 3 months, you can use one of the consultation item numbers. And again, they're just mentioning that with that referral, it's just mentioning the number of sessions that they're being referred for. And then once those 10 sessions are complete, the GP or other medical practitioner can provide a referral for up to 10 more if clinically appropriate. So residents can access up to 20 Better Access sessions per calendar year. So the next part that we're going to look at is a Medicare update. So we're looking at from November last year and the changes that are kind of leading up to and will be kind of in place from July this year as well. So the first bit, we're going to actually start for the changes in July and then work backwards to some of the ones that came out in November. So some of the changes that are coming out for July, the first one I'm going to look at is the MBS changes coming up in July. So there's changes to the Professional Services Review, so the PSR scheme. So from 1st of July, the 80-20 rule will be reapplied to the GP, telehealth and phone items. So under that 80-20 rule, medical practitioner is taken to have engaged in inappropriate practice if they've rendered or initiated 80 or more relevant service on each of 20 or more days in the 12-month period. And then the 30-20 rule, which applies to phone services performed by GPs and other medical practitioners in general practice and consultant physicians. So that will be reintroduced on the 1st of July. So that means that practitioners will be considered to have practiced inappropriately if they render more than 30 phone services on a day more than 20 times in a 12-month period. The other thing is around the telehealth. So those introduced on a temporary basis in response to COVID-19 will now be permanent. And there's some rules around what's considered an established relationship. So it's worth having a look at those recent fact sheets for the changes around the telehealth. Some of the changes that came into place in March were for midwife and nurse practitioner services. So from 1st of March, there's going to be changes to the 3 existing MBS items and the reintroduction of 4 item numbers. So those 4 new item numbers are in place for participating midwife attendances, and there's a fact sheet around that as well. So for those practices that have midwife or nurse practitioner services as well, it's worth having a look at those. The other change that came into place in January was around the rural bulk billing incentive changes. So the bulk billing incentives listed will be amended to services rendered by doctors in MM2 fees, and they will remain at the 150% of the fee for the relevant metro area item. And then the bulk billing incentive regulations will create new items for the doctors in the relevant metro area. So for those in MM3 and 4, 5, 6 and 7, you can see that they've got the 160, 170, 180, 190% of the fees attached to those. There will be no changes to the bulk billing incentives 10990, 64990, 74990 for doctors in the metro areas. One of the other MBS items that came out, there were a number of changes to the MBS in November last year. So for those that haven't had a chance, maybe go back and have a look at the news in the fact sheet section from MBS Online. One of the new items that came out was 11607, so that's for the ambulatory blood pressure monitoring for the diagnosis of hypertension. So the purpose of this service was to monitor the patient's blood pressure continuously over 24 hours via a wearable device to diagnose if they were hypertensive or not. The service includes the fitting of the device, analysis of the data, generation of a report, and the development of a treatment plan, and all consultations that are associated with that service. So for those that are interested in adding that item number, just have a look at the main description and the explanatory notes. So there's some restrictions around co-claiming with other MBS items with that one as well. Some of the other changes that came out in November, in the November update, was around the HbA1c point of care testing. So there's 2 new item numbers that have been introduced. So we've got the 73812, so that's for the management of diabetes, 3 per calendar year, that's for the medical practitioner, that item number. We've got the 73826, that's the management of diabetes, 3 per calendar year for the nurse practitioner. And then we also have existing point of care testing MBS item numbers. So we've got for clinics that are under the QAMS program, We've got the 73839, 73840, and the 73844. So that last one's actually for the year in ACR. The first two are for the HbA1c. One of the other really big changes that came with the November update was the introduction of the Allied Health Case Conference MBS items. The intention for these items were to increase the uptake of multidisciplinary case conferences, to improve the care coordination, minimise duplication of services, and to support the outcomes for residents and their families. We'll have a look a little bit closer for the requirements of these in our next section. Case conferences are a great way to keep all of the care providers on the same page. And for residents that have really complex care and multiple providers involved, it makes a lot of sense for us to have a look at this as a way forward. So GPs and other medical practitioners have had access to MBS items to be able to organise and coordinate, and also to participate in case conferences. So I thought this was a great opportunity, now that these new MBS items are in place for allied health, that we maybe revisit the GP's role in the case conferences as well, as this will actually help with the coordination for the residents. So which residents actually eligible for these case conferences? So the resident needs to have chronic or terminal medical condition and complex care needs. And the case conferencing items that we're going to speak about first are for the GPs to organise and coordinate, or to participate, to ensure that the residents' care needs are met through a planned and coordinated approach. So who needs to be part of that team? So the case conferencing team must include a GP and at least 2 other health or community care providers. And one of those can actually be another medical practitioner. So they want each team member to provide a different kind of care or service to the patient, and they've got examples of who can be included. So examples include other allied health professionals, home and community service providers, care organisers, such as education providers, personal care workers, probation officers. They've also got there that the patient's informal or family carer can be included as a formal member of the team, but doesn't actually count towards the minimum of 3 service providers. And something to note, that the patient does not have to be present at the case conference, though in some cases it may be appropriate. The case conferences can occur face-to-face, by phone or video conference, or through a combination of these. Now the process, we're just going to walk through this process of what's involved. So for the GP case conference, I've got a list of what's included. The recommended frequency, they say, would not usually require more than 5 case conferences in any 12-month period. The claiming of case conference items with other items. So they've said that with health assessment items, Medicare benefits are payable for both items, where the GP carries out a health assessment and case conference service for the patient on the same day, as long as those requirements for both services are met. With the other CDM items, they're saying that the CDM services cannot be claimed in respect of the service to which the case conference items apply. So the one service cannot be used to claim both a case conference and CDM item on the same day. So let's have a look at this first set of item numbers. So this is for the GP to organise and coordinate a case conference in a residential aged care facility or community case conference, or a discharge case conference. So there's 3 MBS items and they're time-based. So the first one we've got there is 15 to 20 minutes, the next one's 20 to 40 minutes, and then at least 40 minutes. The next set of MBS items that we have is for the other medical practitioners. So a medical practitioner who is not a general practitioner, specialist or consultant physician, and their items to organise and coordinate a case conference. So same thing, 3 MBS items, and they're broken down by time limit. So first one's 15 to 20, 20 to 40 minutes, and then at least 40 minutes. The next set of items that we've got is for the participation. So this is when they're not organising and coordinating. This is to actually participate in the case conference. So there's GP MBS items for those. So we've got the 3 MBS items, same thing, they're broken down by time. So we've got 15 to 20, 20 to 40, and at least 40 minutes for GPs participating in a case conference in the residential aged care facility or community case conference or a discharge case conference. There's also a set of numbers for medical practitioners to participate in the case conference. So same thing, 3 MBS items broken down by time. So all requirements must be met for each of those different MBS items. So I think have a look at those descriptors and the explanatory notes around those to just help with the delivery of those case conferences. So with the allied health providers, just going to go into a little bit more detail of what's actually involved and how we can use those in the residential aged care facilities and in general practice going forward. So they've got 3 different criteria. So these all came out from 1st of November last year. So they're eligible allied health practitioners can participate in the different case conferences with medical practitioners. So under the new items, the eligible allied health practitioners may claim the reimbursement for participating in the multidisciplinary case conference through those same, I guess, time-tiered items. So it's same breakdown in the time. So we've got 15 to 20 minutes, 20 minutes to 40, and then over 40 minutes. So for the allied health case conferences, this is a must. So it must be organised and invited by the patient's GP or other medical practitioner, not more than once every 3 months for the allied health providers, and this is in line with the existing team care arrangements. Can be accessed in person by video conference or telephone using the same item, and must record the day, start and end times, name of the participants, and all matters discussed in the patient's record. One of the questions that comes up with the allied health involvement in the case conferences was, do they actually need to have a pre-existing relationship with the patient? So as a case conference can be used to determine the care that the resident or patient may need going forward, these new item numbers do not actually require that the allied health practitioner has a pre-existing relationship with the patient. However, they recommend that the patient must agree to the allied health practitioner being part of that case conference. And then obviously going forward, the case conference may actually lead to having the allied health providers in the patient or resident's care plan. So it may include things like, the number of allied health services that may be required as an example, and how they will be allocated amongst the eligible allied health practitioners with the patient's entitlement for those. So we've got those 3 item numbers, so you can see the same breakdown. So we've got the 15 to 20 minutes, the 20 to 40 minutes, and then greater than 40 minutes available for those providers. Some of the allied health practitioners that can be include Aboriginal health practitioners, Aboriginal health workers, audiologists, chiropractors, diabetes educators, dietitians, exercise physiologists, mental health workers, occupational therapists, osteopaths, physiotherapists, podiatrists, psychologists, or speech pathologists. And then the last set of items that we've got there, so these are for the patients with autism, pervasive development disorder, and eligible disability case conferences. So same thing, they're actually time-based in the 3 time-tiered. So 15 to 20, 20 to 40, and then at least 40 minutes. This brings us to the MBS item numbers. So we've got some additional temporary numbers that are available by using some of these additional MBS items that have come out. So up until the 30th of June, we've got some additional numbers. So these will include the Flagfall items under those temporary pathways. So let's have a look at those now. These are our temporary allied health pathways, just as a recap. So starting from the left, we've got the resident that has the residential aged care plan, plus the GP's contribution under that 731 MBS item, or the resident has completed Aboriginal and Torres Strait Islander health assessment. So either of those pathways, once those initial 5 visits have been completed, there's an additional 5 individual physical therapy services. So that's for a physiotherapist, exercise physiologist, and occupational therapist. And the other pathway is if the resident has type 2 diabetes with a residential aged care facility plan in place, plus the GP's contribution. Once they have used those existing 8, then there's also the 2 additional group allied health services specifically for the EP available. Okay, so this is the temporary pathway in place until the end of June. Once that has come to an end, it will just revert back to the existing pathway. So under the first pathway of the 731, it will revert back to the 5 only. With the residents that have had the Aboriginal and Torres Strait Islander health assessment, it will just revert back to the 5. And for the residents with type 2, it will revert back to just the 8. Now, what they've introduced as part of these additional services to recognise the GP's travel to the facilities to provide those face-to-face and the allied health providers, they've introduced the Flagfall MBS items. Okay, so let's have a look at those. Let's have a look at these Flagfall item numbers. So these are to be used in conjunction with the temporary MBS items. So they can only be claimed for the first resident for the face-to-face attendance at the aged care facilities. So it summarises it in the table. So for the GPs, we've got the 90001. For the other medical practitioners, we've got 9002. Allied health. For the allied mental health professionals, we've got 9003. And the allied health professionals 9004. So the next slides are just going to outline the temporary numbers and the existing numbers. So the existing MBS items for the contribution to the multidisciplinary plan is the 731. The temporary number is the 93469. Same for the Aboriginal and Torres Strait Islander health assessment. The existing MBS item is the 715. And the temporary numbers are the 93470. For the other medical practitioners, the existing item for the contribution to the residential aged care facility plan is 232, and the temporary MBS for the face-to-face item number is the 93475. For the other medical practitioners, the existing item number is 228, and the residential aged care facility face-to-face number is the 93479. Now, the allied health MBS items, they've broken up into initial long and then the subsequent or standard visits. So the initial or long visits are once per patient per calendar year, and it must be face-to-face. And this has just been those additional numbers to support these is to actually support the allied health providers that are providing extended consultations with the residents. Okay. The subsequent and standard visits, this can only be It's actually face-to-face, telehealth or phone, and providers can actually claim the Flagfall for the face-to-face attendances for that first resident. We have created some digital resources to help support the providers delivering services to the residential aged care facilities. So we actually have some MBS billing sheets available for GPs, other medical practitioners, mental health and allied health providers, and they're available in little PDFs to just download and use up until the end of the financial year. To access the digital resources from CDM Plus, all you need to do is to scan the QR code to be able to access those free MBS billing sheets for the temporary COVID-19 item numbers for residential aged care facilities. So you can scan the code, otherwise you can just go straight to the website cdmplus.com.au and on the online modules page you'll actually see the link to actually just click to register and access those resources. In the more information section of the presentation, I've actually got the links to those reports that we looked at in the beginning of the presentation. So the aged care and COVID special reports, the implementation progress report, the National COVID Aged Care Plan, the Royal Commission reports, if you want to be able to access and have a look at those. I've also included the fact sheets around those temporary MBS items from the Department of Health as well. So we've got the temporary items for the GP and other medical practitioners. I've also got the temporary allied health services for the those providers as well. And we've got the mental health support for aged care residents during COVID, so the extension and the fact sheets around those additional services. We've got the questions and answers on chronic disease management, so particularly have a look at that MBS item 731 for the contribution to the multidisciplinary plan for the residential aged care facilities. We've also got the links to those individual allied health services under Medicare, and around the mental health disorders, we've got the diagnostic and management guidelines for those as well. We've got links to CDM Plus for the fact sheets if you want to go through the website that way. And we've also got the MBS telehealth services. For those that want some more information around some of the things brought up in the Medicare update, have a look at the prescribed pattern of services, and then the what is the 30/20 rule coming out, and then just the link to MBS online. So we hope you enjoyed the webinar on the temporary MBS items and Medicare update.